Good morning, everyone, and thank you for joining us for today's special event. I'm Brian Gamble, Senior Vice President at First Long Island Investors. And first and foremost, we hope everyone continues to be healthy and doing well. Before we get started, I'll cover a few logistical items quickly. All participants are currently in listen-only mode. We'll have time for question and answers from the group at the end. Please feel free to submit them as we go along by using the dialog box labeled questions. I now hand it over to Robert D. Rosenthal, our Chairman, CEO, and Chief Investment Officer, to introduce our speaker today.
Thank you, Brian. And good morning to everyone, and thank you for joining us. And special thanks to Dr. Bruce Farber for presenting to our clients and friends of the firm this morning. Dr. Farber gave great webinars during the horrible course of COVID over the past 2.5 years to the board, friends of the board, and friends of the health system. It was incredibly helpful and calming during a very difficult period of time that we all went through. And based on the success of that, we've asked him to do the same thing for our client base that has the time to listen. Dr. Farber graduated from Northwestern University's honors program in medical education with a BS and MD with distinction. He then did a 3-year residency in internal medicine at the University of Virginia. After completion of that training, he spent a year doing a fellowship in hospital infection control at the University of Virginia, followed by a clinical and research fellowship in infectious diseases at Mass General and Harvard Medical School and the New England Deaconess Hospital. He served on the faculty of the University of Pittsburgh Medical School and joined the staff of North Shore University Hospital in Manhasset in 1986 and LIJ Medical Center in 1996. He is currently the Jane and Dayton Brown Professor of Medicine at Hofstra Northwell School of Medicine and Chief of Public Health and Epidemiology for Northwell Health. He has been the hospital epidemiologist at North Shore University and Chief of Infectious Disease at North Shore University Hospital and Long Island Jewish Medical Center. He is currently the Chief of Public Health and Epidemiology at Northwell Health. He has been a consultant to the New York State Department of Health, the National Hockey League, Madison Square Garden, the New York Islanders, and numerous other companies and groups throughout the pandemic. He has authored over 50 peer-reviewed papers, edited 2 books, and has written dozens of abstracts and reviews. So it is my distinct pleasure and honor to turn the program over to Dr. Bruce Farber.
Thanks a lot, Bob, for inviting me. Bob is a close friend of Northwell, a major contributor, both with his time and his money, and a friend. And I can't think of a place that I'd like to talk to more than you. You're lucky to be involved with him. He's truly a prince of a man. So let's get started. If we could, Brian, go through the slides. I'm going to give a presentation with a PowerPoint, and then we will switch to a discussion at the end. Brian. All right. So fortunately, as Bob has indicated, times have changed dramatically since those webinars to the board and the Friends of Northwell. And fortunately, we're in a totally different situation now than we were then. And quite frankly, I don't think many things that applied then apply now. And the major reason for that sometimes people forget is that different viruses are circulating. And although, yeah, they're all COVID, the variants that are circulating now are nothing like the variants that were circulating then. And that's what I want to explain to you, why we are where we are, where we're going, what are the threats, and what is the really good news that I think has allowed us to get back to a reasonably normal life, with some exceptions. So the first thing is that probably half the people on this call have had COVID, and probably some of the people on this call have had COVID more than once. And many of us are going to get COVID this year and next year. So why don't you want to get COVID in 2022? And the reason, if you've been vaccinated and boosted, you're not going to die, as I will show you. But you still don't want to get COVID. Why? Because you can feel awful for between 3 and 5 days. That's the typical course. You will be contagious and must isolate for a minimum, depending upon your job, of 5 full days or a maximum of 10 days. If you have a lot of comorbidities, immunosuppressed, you're very elderly, or you're unvaccinated, there's a possibility that you could end up in the hospital and you could even die. And we're running about, as I will show you, 200 deaths per day in the United States, dramatically down from what we were before, but that's still nothing to sneeze at. And there's a possibility of developing long COVID, which can last for months or longer. And not most importantly, but not appreciated by many people, is the growing evidence that COVID is another risk factor for developing heart disease within a year of developing COVID, similar to hypertension, hyperlipidemia, central obesity, and family history. And none of us want to get that, but COVID does affect the heart. Next slide. So where are we? So this is an easy slide to follow, but in science and in epidemiology, we use this concept called an R0. And very simply what it says is, if you took one person with an infection, let's just say COVID-19 on the left-hand side of the slide in the middle, and you put them in a room with 100 people, how many would get infected within a reasonable period of time? And at the beginning of the outbreak, it was 3, and the R0 was 3. So for every person that got COVID, if you do nothing and you do no mitigation, 3 people will come down with it. And if you look now at COVID on the bottom in the middle, you see the R0 is 9. So the current variants of COVID that are circulating are 3 times as contagious as the one that was circulating in 2020 and 21. Now, that's the bad news. The good news is this strain that's circulating is much less virulent, is much more likely to infect your upper airways than your lower airways, and is responsible for a dramatic decrease in the amount of death and morbidity associated with COVID, which is why so many people on this call and in the country have COVID and are not that sick. Now, just compare it to influenza, which has an R0 of 1.5. And then if you want to see what's really contagious, the only 2 infections that are more contagious currently than COVID are measles and mumps, which are very well controlled with vaccination. Next slide. So don't pay attention to this slide, but I do want to show it to you because when you first look at the slide, it looks like a New York City subway map if you've never ridden the subway. Very confusing, very difficult to follow. But what I want to show you is that these variants are emerging at an unbelievably rapid rate. And this just demonstrates to you how many variants, and most of these are no longer considered variants, they're considered mutations of a variant. And they're literally arising every 2 to 3 months. And the reason why I want to show you this is this makes it very clear that COVID's never going away, at least not in my lifetime. And because these variants just keep coming and coming and coming. And I want to demonstrate this to you with the new vaccine, the B5, and if you can give me the next slide. If you realize that the B5 variant was dominant when they made the new bivalent vaccine, and by the time it came out, B5 is responsible for less than 20% of strains in the United States. So we're constantly going to be chasing our tail. And even with rapid evolution of vaccines, there's no way you can keep up with the speed at which these variants are emerging. That's the bad news. But let's look at all the good news and why we're in a different situation than we were then. So I love to show this slide to people because it's very simple. And what it demonstrates is if you take a healthy 0 to 17-year-old person who is vaccinated, you see that the reference range of them getting a case, hospitalization, and death. Now let's compare that to other groups of people. And what you can see is the incidence on the first slide of COVID is pretty much the same, regardless of whether you're 5 or whether you're 85. Pretty similar risk. For the most part, the risks were a little bit lower in the beginning for elderly people because as a general rule, they were much more cautious. But in recent months, they're much less cautious and they're pretty much very similar to the younger groups. If you look at the hospitalization rates, look at the difference. Even a 30-year-old is twice as likely as a 17-year-old to get hospitalized. And if you look at the rates of an 85-year-old, they're 15 times as more likely. And then if you look at death rates, an 85-year-old is 340 times more likely to die of COVID than a healthy 17-year-old. And the numbers, go down, but even a 40-year-old is 10 times more likely than a 17-year-old. And so this is something just to consider. Next slide. Now, we can also put this on a different continuum. And so age is only one part of it. Look at the top. The lower the risk, the lower the death rate. The older you are, the higher. But if you have one medical condition, two or three, you dramatically increase your risk. And the medical conditions that I'm referring to are diabetes, chronic kidney disease, obesity, lung disease, chronic heart disease, and pregnancy. Now, what about vaccination status? Again, if you're unvaccinated, you're at highest risk. If you're vaccinated and boosted, it's dramatically lower. And so even if you are, say, 85 and have comorbidities, you can move that curve dramatically to the left. And the big difference, which I'm going to show you in morbidity and mortality, occurs with at least one booster. Now, I am an unapologetic pro-vaccine person, but I also think we need to be transparent and honest about the good parts and the not so good parts about these vaccines. And that was one of the mistakes I think people made in the beginning of advertising these vaccines as better than they really were, which made people cynical and skeptical to some degree. And then finally, immune suppression on the bottom. Now, not all immune suppression is the same. Everybody lumps them together, and about 5 to 8% of the population is immune suppressed. But you cannot compare somebody who has recently had a stem cell or solid organ transplant to somebody who's on a biologic therapy for psoriasis, for Crohn's disease, for rheumatoid arthritis, or for many other diseases. You can't compare a woman on chemotherapy for breast cancer to a bone marrow transplant patient. They're dramatically different in terms of the level of immune suppression. Next slide, please. So this is the slide I wanted to just show you. The B5, this was 2 weeks ago, and it's changed since then, accounts for 24% of isolates in the United States. That's what the new vaccine was directed against. And so keep that in mind, that new vaccines can't keep up with these variants as quickly as they're emerging. Next slide, please. So what about New York? Let me show you the data, and my talk will always be data driven. But if you look at what we have here, BQ11.11 in the US, and New York State has the highest percent of BQ11, about 50% of all our strains. There's really been minimal increased risk of hospitalizations, and that's good news. It's been very modest, but as you can see, remarkably stable. Next slide. If you look at the United States today, it's all good news, quite frankly. The cases have leveled off, even though we have new variants. The death rates have fallen, as I will show you, and hospitalization rates are steady or minimally up in selected areas and down in most areas. Next slide. And if you look at the pandemic low, this is worldwide data, you can see that death rates are falling all over the world significantly. Look at November compared to March. I mean, those are dramatic differences in terms of the deaths per day. 12,000 down to about 2,200 deaths, 2,000 per day now. Next slide. And Europe hasn't looked this good. New COVID rates are down in virtually every Western European country. Again, really remarkable how low they are and how they're falling. It is really pretty safe to travel to Western Europe. Next slide. Now, where has the US fallen off? And the US has done a lot of good things, but a lot of bad things, and I will show you. So let me just demonstrate to you the importance of at least one booster. So these looked at rates in Japan, which has a very obedient population, both in terms of masking and in terms of vaccinations. But if you look at the first two vaccines that were given on the left-hand side of the slide, you can see Japan exceeded the US, but not dramatically. They were about 80% of the population, somewhere in the high 60s to 70% of the population of the United States ultimately got 2 doses of the first set of vaccines. But then look what happened. If you look at one booster, forget the bivalent booster, but just look at one booster. In Japan, it was virtually the same, if anything higher than the group that got the initial, over 80%. In the United States, it's still only about 40% of the population has gotten a booster. Next slide. Well, look at the difference of death rates, okay? And although all these death rates are down, there's a 9-fold difference per capita. Cumulatively, there are 45,000 deaths in Japan and well over 1 million in the US, and that translates into roughly 1 in 2,800 people in Japan compared to 1 in 315 in the US dying of COVID. And that's really dramatic, and that shows you the importance of one booster. Next slide. Now, let's look at new daily cases. And I want to demonstrate to you that this drop-off is so profound in terms of rates of death that you can see that in October, which was not very far away, we were seeing 443 deaths in the US per day, and now we're down to 287. Next slide, please. Let's look at death rates by vaccination. And please, just if there's one thing to take away, it's this slide. Look at current unvaccinated death rates in the US. And this is death rates per this slide, it was per 100,000. It's roughly 8 per 100,000 in unvaccinated. If you look at people who got the primary vaccine, it goes down to 1.5. If you look at people who got at least one booster, it goes down to under 1. And for those people who've had 2 boosters, it's significantly under 1. So you can cut your chances by getting at least one booster and dramatically by getting at least 2 boosters. Next slide. So what are the problems? I've given you mostly good news, and it is good news, but this BQ11, which is circulating in New York, did do some damage. And this is the damage. It essentially eliminated monoclonal antibodies as a treatment for people with mild COVID, and it eliminated Evishield for people who are immunosuppressed. And that's very sad and alarming because many elderly people who got COVID would give monoclonal antibodies to decrease their rates, particularly people over the age of 80, even though 85 I showed you on the slide, and all the people who are immunosuppressed or an elderly person with lots of comorbidities. I was very loose in giving monoclonal antibodies. That's gone. They just don't work against the current variants. And the same thing with Evishield. Next slide. So Evishield resistance is spreading throughout the world. This is not a problem in the US. This is a problem worldwide. It's 100% in India. And although I just made these slides very recently, yesterday, the FDA removed Evishield and Benlivimab from being used in the US because of poor efficacy, because the growing number of BQ11 strains. So we notified all of the people who are getting Evishield who are immunosuppressed through letters and phone calls that they should no longer consider themselves safe and have a false sense of security. And we're no longer giving them additional Evishield, which was given every 6 months. Next slide. So I do urge a benefit of a fall campaign for boosters. They are necessary because there are no other mitigation factors being used. As you are all well aware, and I am aware, masks are gone. I go to a gym, I don't wear a mask anymore. It's too hard to exercise with a mask on. And I do go to restaurants, and so does everyone else. Yes, there are some people who are still more gun shy than others, but vaccines are the only mitigation technique that is available. And that's why I strongly encourage you to do that. Only 36% of people over the age of 50 have received their second booster dose. That's not good. Next slide. The dual benefits. A fall campaign that covers flu and COVID would prevent more than 75,000 deaths in the United States, more than 745,000 hospitalizations, and generate a savings in healthcare of over $44 billion. This is remarkable. And unfortunately, we're not seeing very good uptake on the flu vaccine, which I want to spend a little time with you on. Next slide. So this is, again, one more illustration of the data. If you get 2 boosters, you reduce your rate of death by 96%. Whether you're a sports bettor, whether you're an investor, whether you're a gambler, there's nobody who wouldn't take a 96% bet on virtually anything, because that's an amazing bet to have. And just look at it, unvaccinated, primary vaccine only, vaccine with 1 booster, and vaccine with 2 boosters. And there are very few things in medicine where you see that dramatic effect. If I showed you that data on preventing breast cancer or colon cancer or an auto accident or anything else, you would say, I'll buy into that technology immediately. Next slide. So what about the new booster? Now, this is where I want to be transparent. I've already told you that basically B5 is gone, and the vaccine or the booster that you're getting contains B5 and the original strain. So somebody could certainly raise their hand and say, why should I get this bivalent booster if it's already out of date? And going forward, it doesn't look like Moderna and Pfizer are going to produce with their current technology boosters in time to replace it. And the answer is you're right. And if you look at the bivalent vaccine in terms of neutralizing antibody against BQ11, it's mixed. It does raise antibody levels, but in some studies, these are 6 different studies, you can see it's not dramatic. Yeah, it goes up 4-fold, 1-fold, 10-fold, but compare that to what happened during the first wave, the 20 wave, where you saw 30-fold rise in titers. So the answer is that these don't do a great job in preventing bivalent vaccine or boosters preventing COVID. And that's why COVID continues to circulate. But they do a good job in preventing you from becoming seriously ill, winding up in a hospital and dying. And that's the point of these vaccines. And that's the message that we need to give to people. And it's very similar to the flu message. Flu vaccine is not a great vaccine. A great vaccine is a measles vaccine. It protects 99% of people completely for decades and decades. These are not that. The flu vaccine protects you at 50% level and lower in people over the age of 80 from getting the flu. But it does protect you from dying from the flu or winding up in the hospital from the flu. And that's the same thing that is occurring with COVID. And this is going to be our future. Yeah, you'll need more boosters. Quite frankly, I don't think the data would be different if we used the original booster compared to the new bivalent booster. And I think one of the things we learned is that new boosters are not going to change the natural history of COVID. Next slide. So let me just show you, there is one study, it just came out November 22nd, that looked at the bivalent vaccine in preventing COVID. It was a good study. It was supported by Pfizer, but that's their job. 360,000 people were tested. 34% of the people had COVID. And among these, 24% of people reported being unvaccinated. 72% reported receiving 2, 3, or 4 monovalent vaccines, and 5% received the bivalent booster. Next slide. And what you could see is among individuals who received greater than 2 monovalent doses, that's the original vaccine, relative vaccine efficacy increased with time since their most recent vaccine. Not dramatically though. At 2 to 3 months and greater than 8 months after the recipient of a monovalent vaccine compared to the new bivalent vaccine, the rates were 30 versus 56% among those age 18 to 49, 31 versus 48% in those 50 to 64, and 28 and 43% of those over the age of 65. So that's the data. You can say it's good, you can say it's bad. It is what it is. Next slide. Now, a couple more slides on COVID and I'll switch gears, but I do want to put in a plug for Paxlovid. And again, although not perfect, not only does Paxlovid decrease death rates, and not only is Paxlovid pretty much the only game in town because monoclonal antibodies are no longer available. We do have remdesivir, but it's a nuisance to give. It's 3 days of infusions. But there's now emerging data that Paxlovid decreases the rate of long COVID. And that's something that we all want to avoid Because even though if we're not going to get sick in the hospital, no one wants to feel crummy for 6 months to a year and be at increased risk for heart disease. And so this was another very good study that showed that there was a 48% reduction in death and a 30% reduction in hospitalizations after the acute phase in those people who got Paxlovid within 5 days of being diagnosed with COVID. Next slide, please. And the VA study looked at long COVID, another good study. The VA study evaluated 9,000 patients treated with Paxlovid between March and June of 2022, and it revealed a 26% reduction for the occurrence of long COVID in patients treated with Paxlovid. Not perfect, but 26%. And that's not a bad number considering how relatively safe, effective, and cheap Paxlovid is. As you know, it's currently free. That is all going to most likely change in January. The vaccines are not going to be free starting in late January unless there's a dramatic change in congressional action, and they will cost between $100 and $150. Next slide. And this again is a demonstration of Paxlovid and long COVID and death rates. And on the top, you can see the difference between long COVID and a placebo, and on the bottom, between long COVID and a placebo and death rates. And again, very good data published in very reputable journals with large numbers of people. And the viral load was significantly reduced with treatment, meaning these people were less contagious. Now, the downside of Paxlovid is that 5% of people rebound. And rebound means they feel better, and then they feel worse again 3 to 10 days later. And they are theoretically contagious and need to be re-isolated. And that's the downside of Paxlovid. It turns out that about 2 or 3% of people with regular COVID relapse. It was never paid attention to. And both the relapse in COVID treated patients and in regular patients always gets better. So they don't need to be retreated, but they are theoretically contagious. And that's the downside. So my own personal preference is that if you're 85, I'm going to recommend Paxlovid. If you are a healthy, vaccinated 17-year-old, I don't think you need Paxlovid. I don't think you need anything really, unless you have some serious underlying medical problems, because you're going to get better quickly and you have a remarkably low chance of being hospitalized and dying. Again, I would change that formula if you had 4 comorbidities, or if you were immunosuppressed, or if you're unvaccinated. But the typical, 35-year-old who's vaccinated and not sick probably does not need Paxlovid. Next slide. And this is specifically looking at reduction in Paxlovid. And I want to show you what was reduced so you get a feel for what long COVID really is. And you've probably heard what it is, but it's cardiovascular complications, which I alluded to. It's fatigue, which is really disabling. I mean, people just are tired. They don't want to work. They don't want to play golf. They don't want to go out to dinner. It's really very disabling and a terrible symptom. They have gastrointestinal complaints. They have kidney issues. They have musculoskeletal issues, which overlaps with fatigue. They have metabolic issues. Their diabetes gets worse. Their renal disease gets worse. They have fog brain or neurologic problems. They can't concentrate. They have difficulty working, and they're short of breath. None of these symptoms are fun. And so Paxlovid did help with all but 2. It didn't change the metabolic. That was not significant. And it didn't change with the cough and shortness of breath. But all the rest were better with Paxlovid. Next slide. So I'm going to change gears and briefly talk about flu. It's a very, very interesting paradox that despite the fact that our COVID death rates in the United States can potentially this year go down from 120,000, which were predicted, to perhaps as low as 80,000 if death rates continue to fall. At the same time, based on current predictions, it would not be surprising to see death rates due to influenza in the United States climb from virtually none during COVID when flu disappeared to potentially between 60 and 70,000. And that's what we're seeing in New York right now. There are 15 people hospitalized in my own hospital at the present time. There's been over 2,500 deaths in the United States already from flu, and flu is not, an upper respiratory infection. It's a very serious infection. And although there's overlap with flu, it is a significantly different disease than COVID. It doesn't cause long or post-fluenza the way COVID does, and it is very seasonal, unlike COVID, which really can occur year-round. Flu really occurs between November and March. But look at the increases. They're dramatic and they're occurring weekly. Next slide. And they're across all age groups. And flu tends to kill young children and elderly people much more than COVID that spares young children. Next slide, please. Now I want to show you, New York has a lot of flu, but nothing compared to the Southeast. And that's in the dark purple. And the darker the area, the more the flu is. And 19 states have very high flu rates. Now, I didn't have time to show you this, but there's pretty good data that the severity of flu as well as COVID in states, and it's just coming out, and I think you'll see the data that there were more deaths in states that had lower vaccination rates, and the same thing is applying to flu. Now, that's not to say that this isn't going to be worldwide, and I also have to say that New York doesn't have particularly good flu vaccination rates. As a matter of fact, nowhere in the United States are flu vaccination rates good. Why? This is a function of vaccine fatigue. It's a function of anti-vaxxing. It's a function of people just don't want to get the vaccine. And I think it's unfortunate. I really do. Last year, we had a nurse. She was 28 years old. She had 2 children, all younger than the age of 5. 3 children younger than the age of 5. And she died of influenza. And, her family, her father is a cardiologist who worked at one of the hospitals and wanted to go on TV, was so upset, and the grief over losing a daughter who didn't get the flu vaccine was just horrible for the family. Next slide, please. So let's talk a minute about RSV, and then we can move on to China. And if there's time, wrap it up with Ebola or leave this open to discussion. So RSV, as you know, is the 3rd serious respiratory illness that we track. There are dozens of other respiratory viruses. The common cold, by the way, is a rhinovirus and an adenovirus. Common colds and adenovirus, as a general rule, make a lot of people miserable, but their major impact is on the economy in causing absences from work. They don't kill people. They don't hospitalize people. Even immunosuppressed people who get rhinovirus very rarely get very sick. I mean, I get miserable with a cold, but for the most part, I go to work, I still go out to dinner, I still socialize, and I just bear it. That's not the case with flu and COVID and even RSV. Now, RSV is a virus that also causes a nasty common cold, but in a healthy adult or a healthy child, it's fine. I mean, it's just a slightly more nasty cold than we get, and you deal with it. And most regular adults who get RSV don't know it's RSV because they don't go in and get a viral test to look for it. They may make the diagnosis may come through them getting an RVP looking for COVID or flu, and they say, no, you don't have COVID or flu, but you have RSV. But they're not that ill, and they continue to work, and that's what happens. But if you are a young infant, or you're under the age of 5, and particularly those who are newborns, or you're over the age of 80, then RSV can cause serious illness. In our children's hospital now, there are roughly 320 ER visits per day. That's the norm is 180 to 200 per day. So roughly another 120 people are being seen every day. This is not a good situation. It's not good for the children's hospital. They're trying to do something because there was a 6-hour wait during the peak of RSV at that hospital, which is not good. It's not acceptable. We all know it's not acceptable. But because pediatric programs have closed in most hospitals and parents are uncomfortable, particularly with young babies and infants, of bringing their child to an urgent care center, pediatric hospitals have done phenomenally well in attracting young, sick children. And I mean, I feel the same way. I did that with my 2 young grandchildren who who both got horrible influenza several years ago. The good news is rates are falling for RSV. We've seen the peak, and they're falling across the country, and they're falling across the Northeast, the Midwest, and for the most part, the United States. And that's all good news. I'll also just say about RSV, it's a different virus. COVID is spread by the respiratory route. Influenza is spread by the respiratory route. I know many people on this call were very careful with their takeout food and Amazon packages in the beginning, but I never thought that was the case. I don't use Purell to prevent COVID because it doesn't work. I do use Purell to prevent RSV because RSV is spread by contact, meaning you touch something and then you touch your conjunctiva of your eye or your nose, and that's how you transmit RSV. The average person in the United States touches their nose 10 times per day. If you don't believe me, there's good data with video showing that. And so when you touch something that's been contaminated with RSV, particularly in a daycare center or a school, then you touch your nose or your conjunctiva of your mouth, then you get RSV. Next slide. All right, I'm going to just hold the slides and switch gears and talk a little bit at Bob's request about China. Now, I think you all know that China has literally painted itself in a corner with how they have handled COVID. And it is remarkable for such an industrious society to have done such a miserable job in how they have handled COVID. I'll also say that, as you know, the Chinese culture is very much, if you've read any of the books about it, has very much involved in face saving. They never admit mistakes. They always have to find a way to make sure you think they're right, even when they're dead wrong. And that's very important in negotiations. If you're doing business with them, if you're doing diplomacy with them, they just don't accept arguing. And, that's just the way business is done in China. So, Xi Jinping cannot back off on his zero COVID strategy. On the other hand, he has to back off. As you would know, there's social unrest. The economy is being paralyzed. And quite frankly, it is not sustainable. Now, most people bet that right after his appointment for his third term, there would be a quick dialing down of the zero COVID policy. And that has not happened to date. And the reason it has not happened to date is complicated. And I certainly can't speak to the politics of China. But what I can speak to is giving you some data on why their decisions are so difficult and why they do not have an easy way out of this problem. And that's based on the following data that is gleaned from data that has leaked out of China. And it may be off, but it's probably not that off. And the data suggests the following, that less than 10% of the population of China has immunity to COVID. And in the United States, that number is well over 70, well, it's 90% if you include vaccines. So they have 1.4 billion people in China. Less than 10% means they have an enormous number of susceptible people. If you look at their vaccines, they have predominantly used the Sinovac and the Sinopharm vaccines. Now, those were Chinese-made vaccines. They were not messenger RNA vaccines. I don't think any legitimate scientific organization would suggest that these are good vaccines. They were given away to a lot of third world countries by China who couldn't afford Pfizer and Moderna vaccines. They never bought Pfizer and Moderna vaccines with any degree. I'm sure they bought it for the special people who get what they want in China, but they were never given to the masses. And so now China is a poorly vaccinated country and without a great vaccine. And as I showed you, if you look at the booster rate, which is the most important parameter to look at, you find that even with the crummy vaccines that China used, the majority of the population never got a third booster. Now, they have just put out a vaccine that is very interesting, quite frankly, and not available in the US, and that's a nasal viral vector vaccine. And, it's very novel, and nasal vector vaccines might be the future. Many people think that, but there's no data. And, they don't publish their data in reputable scientific journals, and they don't have to do it in American journals, but they do have to do it in reputable journals, whether it's the Lancet or, other journals for people to judge. And so it's still a very, very difficult read. But what we do know is modeling. And the modeling suggests that if they ended their zero COVID policy immediately, that they would have an enormous spike in COVID. The estimates are anywhere from 1.5 to over 3 million deaths in pretty rapid succession. In addition to which, they would be seeing, what's the number? Over 160 million cases potentially of COVID in a large outbreak within a very short period of time. No one knows the exact number of cases that are currently occurring, but the estimates are that somewhere between 10,000 and 70,000 cases of COVID are occurring in China now, despite their zero COVID strategies. I'm sure most of you have read, but the pictures are really quite amazing what these lockdowns are. And as difficult and as a repressive country as that is, these lockdowns are horrendous. They literally lock the doors of apartments. They give them food, every so often. It's not fresh. And these people are totally isolated. And it is not sustainable. I mean, I'm not naive enough to think that the social unrest will overtopple the current regime, just like, we can only wish for those things in Iran. But nevertheless, it is a very difficult situation in China. And as, Bob points out, the repercussions are profound. And I don't mean only for China. They're profound for investments. They're profound for our supply chain. They're profound for energy and all of the companies that use China to make, everything from iPhones to clothing. And that is going to be a profound implication on the economy. My own opinion is that they will slowly dial down the zero COVID policy. And the only thing they can do to make that somewhat easier is they're going to massively start vaccinating people to give those third doses. And so what I think reasonable people expect to see is a middle ground. They won't eliminate it, but they will slowly dial it down because they have no choice. But at the same time, they will dial up their vaccine rates. COVID rates will go up, but it's their only option, and they will accept a reasonable number of deaths because they didn't have them in the beginning. And so, it's like, you can pay me now or you can pay me later, but you're going to pay somebody, and that's what's going to happen. And they're fortunate, at least, that it'll be a variant circulating that is not nearly as fatal as the first variant. So that's where I think, it stands with them. I really don't know what that leadership will do, but it is shocking that they have done what they have done. And it's just, to me, it's mind-boggling how wrong they were and how they keep doubling down on a policy that just makes no sense. I mean, it's destroying their economy. It's isolating them. As you know, no one goes to China. No one can go to China, even if you're doing business there, without isolating for 2 weeks in a state-run hotel. I mean, how many people are going to want to do business in China with that in mind? So Bob, I can stop here and we can talk, or if no one has discussion items, I can go back and finish with Ebola, whatever you guys want.
Bruce, I'm sure. Let me ask Brian. Brian, do we have a number of questions for Dr. Farber?
We do.
I know I have a few. Okay, so.
Well, Bob, why don't you lead all? All right. So for now, thank you very much for your presentation, Dr. Farber.
Oh, it's great.
Why don't we? Yeah, it was a wonderful presentation. Well, let's maybe get some questions.
Let me lead off with one.
I was going to say,
right?
Bob,
because it was fresh on the data that Dr. Farber just gave us on China, which does have, besides the medical implications and the sadness, it does affect the global economy. It does affect what's going on in the U.S. And that's why I asked Dr. Farber to speak to this issue. But even if they were to reduce this zero tolerance, which you're suggesting they will be forced to do, and they want to do massive vaccinations, it sounds like the vaccine that they're going to be using is what the original problem was, because since they do save face, they should have been ordering Pfizer and Moderna vaccines to begin with. They wouldn't be in this pickle if they had done that. So how efficacious is the vaccine they're about to use, or the booster they're about to use, if they reduce the zero tolerance?
Yeah, I mean, first of all, no question that Moderna and Pfizer, and, I'm proud to be an American, and we did some things wrong, but look at what we got right. And they, what they're like. So the answer is, I don't know, and no one really knows, other than to say that the way they could at least luck out, if you want to look at the optimistic version and the pessimistic version, the optimistic version is, they're not very effective, but in view of the fact that it's Omicron and not the original strain,
Right.
and it's much less virulent, it'll get them by. And, that's sort of what's happened in a lot of countries. That's what's probably happened in Russia and these other countries. And, we don't have good data from some of these third world countries, but I think that's sort of what they're banking on. They're certainly not going to invest in 1 billion doses of Pfizer and Moderna unless, I can't imagine they're going to do that. And that's why it's such a difficult situation. And, I don't see an easy outcome. And I think that it will evolve over a year or two. I mean, it's not going to be a quick fix. And even if they get through this, there'll definitely be at least a 3 to 6 month severe effect on collateral damage in the economy.
Do you know if they're using Paxlovid?
Not to the best of my knowledge, they're not using Paxlovid, and I don't know whether they will copy it. As well as I, they're very good at copying. Yeah, exactly. But no, they're not using it as of now.
Okay, great, thank you. Brian, why don't you give Dr. Farber some of the questions we have from our audience?
Okay, great. So first question, Dr. Farber, many people have caught COVID despite their vaccination level. Does catching COVID provide any level of defense against future infection, even regardless of their vaccination level?
Yes, there's no question that you will not get COVID in the first 30 days after you've had COVID. And there's no question that you are dramatically at lower risk of getting COVID in the first 90 days. The problem is, in the old days, as with the first vaccine, the first variant, it could protect you for a year. But now, because these variants are changing so quickly, that yes, you can get COVID after 30 days and definitely after 90 days. The data suggests that the average person gets COVID again about 180 days after their first episode. But it varies. It could be 40 days and it could be 240 days. But yes, there's no question. In addition to which, I don't think we're smart enough to understand why patients tell me, and they're smart and know, and some people ignore COVID and some people are anally compulsive about keeping track of this. But I have a patient who clearly had COVID 6 times, okay, and was fully vaccinated and boosted. And I have other people who have never had COVID. And make no mistake, someday the genetics of this will come out. They're already working on this, that suggests, like all infectious diseases, not everybody has the exact same susceptibility. I mean, look at smallpox and look at HIV. 5% of the population never got HIV, even though they did high-risk population. And there's great data that came out. The New York Times featured it, but showing the same thing happened with smallpox. And, just remember, and I don't want to get off on a tangent, but remember, COVID has killed about 0.3% of the world's population under the worst scenario. Smallpox killed 40% of Western Europe during the Great Plague. I mean, that's a mind-boggling statistic. Yeah, I understand the world's population wasn't anything what it was now, but that is just amazing to have understood.
Okay, great, thank you. All right, so hopefully another pandemic never occurs, but that's unlikely to the extent that we had with COVID. But if one were to, do you feel we are better prepared to react and handle it domestically and globally, given the experience and the lessons learned from 2020?
Yeah, so let me answer that with 2 things. Number one, just so you know, the only infections that can produce a global pandemic are respiratory. So when you get excited, and I'm not going to cover it, because a case of Ebola slipped through Uganda and wound up in New York or DC or Atlanta, or about Zika virus, or about Lyme or HIV. None of those viruses are infectious diseases, which can threaten us like monkeypox, but they will never cause a pandemic, because pandemics can only occur when something is so contagious. And the only things that are that contagious are agents that are spread by the respiratory route. So if you're worrying about another pandemic, and if I were a betting person, which I am, I would always bet on influenza. And everybody bet on influenza and not on a coronavirus, because coronaviruses cause common colds and influenza does this. And someday we're going to see another influenza pandemic. We've had 3 in the last century, one that was horrendous. And, and the last one was H1N1 in 2009. So yeah, there will be another flu pandemic or another pandemic. Do I think we're better prepared? In some ways, we're much better prepared. In other ways, no. And I don't want to go through the great details, but I will tell you in short order that, the beauty of the United States and its downfall is we don't control anything centrally. Israel put out all of the good data on the effectiveness of the vaccines because we don't have centralized data in the United States. If you have a healthcare plan with Northwell or Oxford or Medicare, it doesn't talk to another plan. There is no central electronic medical records that allow people to keep track in large numbers. When I show you these data of 350,000 people that are following, that have followed for COVID, most of it doesn't come from the US. Yes, some came from Kaiser Permanente and some came from the CDC, but that's where we have not done a very good job. And the other place where we have not done a very good job is investing in public health. If I told you, which I will tell you, the Nassau County Department of Public Health, and I'm saying this in public on a recorded line, before COVID and even now, has many less employees than your firm does. And, it's literally like the Wizard of Oz. There's no one behind the curtain. And so as a matter of fact, large health institutions like Northwell, like NYU, we call them the Big Five, Mount Sinai, Montefiore, had to assume the role of doing a lot of the work because those resources are not funded and not available.
Okay, great. Thank you. So let's switch a little bit here. Is herd immunity a real concept? And if so, how close are we to achieving it in the US and North America?
Well, if you're asking if herd immunity is going to ever occur the way it's occurred with measles, the answer is no. I mean, I showed you those variants. COVID's not going away. I mean, we're going to live with COVID. I don't think we're living a horrible life, but if I told you we're going to continue to live with security issues at airports, we're going to continue to live with other changes, we're going to continue to live with hacking our computers and cybercrime and all the things that threaten us. The answer is yes, COVID's around, like I said, for the rest of my life. But, we'll get through it. I mean, it's becoming endemic. The optimistic view, which I do have, is that, unless there's a dramatic change in these variants, the worst thing that'll happen to me in the next year is I'll get COVID once or twice. And hopefully I won't get long COVID. Hopefully I'll treat myself with Paxlovid to decrease that risk. And, and I'll live. And that's, I think, no different than me doing a lot of other things that are risky.
Okay, so you talk about the variants and the mutations for COVID. Is it possible that some mutation or variant could become so powerful that it causes a significant number of deaths on top of what we've already seen?
So it's the Sigma variant that you're probably referring to. There's a new variant out there that people are looking at. It has not spread into the population. But yes, of course, none of us can bet on, anybody. It's a fool's bet to bet on the future of COVID. I mean, I lost that bet so many times. No one guessed it would cause heart disease. No one guessed it would cause chronic COVID. No one guessed that it would change and all these things. So yes, I mean, fortunately, we do have at least a year now of seeing these variants. But yeah, I can't predict that.
Okay. All right. So can you share with us any particularly interesting, second order impacts from the COVID epidemic on the healthcare system that people really aren't thinking about, including maybe, using mRNA technology to solve other diseases, anything like that, additional drugs being used along those lines to maybe combat other comorbidities to prevent, some of the more severe cases of COVID, such as, with things like obesity and things like that.
Yeah, that's a great question. And like I said, I think we've made a monumental leap with these RNA vaccines. I know people were anti-vaxxers, but, to me, it's literally like if you could turn water into oil, it's so good. And yes, I think that's going to lead to a dramatic change. There's new flu vaccines being studied. Pfizer would sell itself, to anyone if it can find a common COVID antigen so that it doesn't have to worry about all these variants. That's, number one priority. They've done a very good job in their R&D. I mean, people criticize those pharmaceutical companies, but God bless them with what's happened. With a lot of money, by the way, from the NIH. So yes, I think those things are coming and they're coming fast, but how fast? The big problem has been no one visualized the rapidity at which this virus would mutate. Flu doesn't mutate that quickly. I mean, months go by and suddenly there's a new variant, and that continues to happen.
Okay, great. So just a follow-on question. Are there any vitamins or supplements or minerals that we could incorporate into our diet that would help, reduce the risk of catching COVID and improve our body's ability to fight it off?
I wish I could say yes. I know, it's always good to exercise and eat right and stay healthy and avoid all the metabolic disturbances that we get from overeating. But I can't recommend, based on evidence-based medicine, that a specific vitamin or food additive will do that. There's just no data to support that.
Okay. So another question, have there been studies regarding the effects of COVID, the current vaccines and boosters on pregnant women or those who plan to get pregnant in the future? Are there any risks there?
Oh, absolutely. Yeah, I don't think there's any question. That ship sailed a long time ago. But let me just tell your listeners that the latest numbers are over 4.5 billion people have received a messenger RNA vaccine in the world. I mean, that's an astonishing number in healthcare. I mean, it's an astonishing number in any study. And, to the best of my knowledge, I don't think there's been one well-documented death out of those 4.5 billion. So that's point one. Point two is I don't think there's been a safer vaccine that we've ever seen. We use much riskier vaccines in kids all the time. MMRs are much riskier. And I don't mean in terms of autism, I just mean in terms of other side effects. So these are very safe vaccines. They're very safe in pregnancy. Paxlovid, I don't recommend in pregnancy unless I've had a thorough conversation. Because unlike the vaccines, I don't think there's enough data to make an absolute claim about its safety in pregnancy. So I have a conversation with a pregnant woman based on her morbidity and her risk factors and where she is in the pregnancy, and leave it up to her to make that decision. And I'll make a recommendation, but it's not based on enough data that I feel comfortable giving firm advice of Paxlovid during pregnancy, but definitely the vaccine. And that's why, by the way, I'm so sad to have lost the monoclonals, because I gave the monoclonals ad lib to pregnant women all the time.
Okay, great. So just talking generally about infectious diseases, how are they changing and what are the challenges we face in fighting them going forward?
Well, I don't know if any of you saw the media picked up on Fauci wrote basically a goodbye article in the New England Journal this week, an editorial. As you know, he's retiring at the end of the year from his position at the NIH. And, he quoted Yogi Berra in the article when he said, it ain't over till it's over. And basically what he said is, with infectious diseases, it's never over. And I think people need to get away from the concept that we're not going to be constantly fighting infectious diseases. You have to believe that the earth is flat to think that infectious diseases are not going to continue to evolve, whether it's COVID, whether it's flu, whether it's HIV, whether it's rhinovirus, whatever it is, Lyme, new infections are always going to be cropping up. That's the nature of Darwin. That's the nature of survival of the fittest. That's why the best win. And that's what's happening, and it continue to happen. What we need to do is just to stay one step ahead of them. And I think we can do that, but we're never going to eliminate them. I mean, there's this great article, and Fauci basically alluded to it, although I remember the original article because I used to make a slide of it, that said in Newsweek magazine, which, is probably gone, I don't know if it's still around, but was really popular in the late 80s and when I was there. And it said that if we can hold out till the year 2000, all infectious diseases will be gone because of improvements in antibiotic research. And, look at what's happened since 2000 in terms of infectious diseases, and they're never going to be gone.
Okay, so that's the last question that I have. Bob, did you have anything else you wanted to
Yeah,
chime in?
I have a few follow-on. This is such a fascinating discussion, and I know how helpful it is for me to hear Dr. Farber, and I'm sure everyone else listening feels the same way. In terms of going forward, I would say the majority of people on this call, not all, but the majority are over 50, relatively good shape. Should they be taking a COVID booster every 6 months? Since it's not a seasonal disease like the flu, is that something that you would recommend, or is it over 65? But how do we go forward, recognizing that COVID's not going to end? It's going to be around with variants. What would you prescribe to us going forward as a reasonable routine to try and mitigate the worst effects of COVID going forward?
Yeah, and I'm certainly a member of that club. And so what I would do is, pretty much be up to date. And up to date at the present time is your original 2, and then, at least 2 boosters thereafter, and then the bivalent booster. So I've gotten 5 shots of COVID to date. Now, my next booster, I don't know when it will be, and I'm not willing to say yet. It will be at least 6 months, if not a year, from my last booster. And I think the jury is still out in looking at that and looking at what variants are available. And so I think it's a dynamic process, Bob, but I'm holding out on my next one, but I know that it'll be before next October.
Okay, so somebody just recently had COVID and they've recovered. Should they typically wait 6 months to get their next booster? Is that reasonable?
If they're not up to date and they haven't gotten the bivalent booster, and by the way, that's the only booster available now. Remember, they removed the original booster from the market, so you can't even get it unless you've never gotten vaccinated. Then they'll give it to you as a primary. But if you've never gotten the bivalent, then I wait at least a month before getting it after your last bout of COVID. You can wait as long as potentially 3 months, but somewhere in that range.
So definitely get the bivalent.
Oh yeah, there's just no downside. That's
Right.
That's the thing. It's not a great vaccine, but yeah, my arm really hurt. I got Moderna last time, but I mean, it's nothing compared to.
And that's an interesting point. It sounded like you just got Moderna, but had you had Pfizer before then?
I did. I had all
mix?
Pfizer. Yeah, I switched to Moderna. There's very soft data that mixing it up is beneficial, particularly in the direction of Pfizer going to Moderna as opposed to Moderna going to Pfizer. And there's very good data that I doubt anybody has it, but anybody who got J&J vaccine should really switch to Moderna if they did.
One last question. Masking. Does it help? Is it worthless? Especially as we go into the holiday, we're in the holiday season and we're traveling in airports or whatever, is it any help at all to wear a mask?
Yeah, and it's interesting. There's amazing amounts of information, and particularly for those of you interested, literally this week in the New England Journal, and I just didn't have time because I have it in slides, is an article that came out from Massachusetts. It was a fascinating study. What they did is in February, everyone in the schools in Massachusetts decided they're no longer going to require masking. And that was done basically throughout the United States. And for good reason. There's a lot of reasons why kids shouldn't have to wear masks in schools. But what they did is they tracked those school districts that eliminated the mask requirement and compared it to those that didn't eliminate it. And there was a dramatic increase in COVID in the children and the teachers and the staff. Dramatic. The increase was responsible for 30% of all cases of COVID. So masks work. How well do they work? They work at a level of about 50%. By no means 100%, but they do decrease transmission rates by about 50%. And so they work. Now, you could ask me, well, is it worthwhile? And I'm not here to argue whether, that increase in COVID rates in Massachusetts was worth having 5-year-olds be able to be seen by their teacher without a mask. It interrupts with communication. I mean, I went to see a Broadway show over the Thanksgiving break. And, in the theater, I would say, I don't know, maybe 20% at most had masks on, probably less. And so that's an individual decision that can be made, but they do help.
Great. Thank you. One last question in terms of what sounds like the waning interest of the government in educating people to get the bivalent booster, or for that matter, the flu shot. And when you look at the enormous savings to the country and by having a flu shot or by taking the COVID booster, do you think the government should be doing more? Should they be continuing the free vaccines or the free boosters or both going forward? Should we be urging our Congress people to be doing that?
I do think that. I mean, I think if COVID uptake on vaccines is poor now, you can imagine what's going to happen when you can't get out of the office without writing a check for $150. And, you know, flu vaccine for the most part is very cheap and covered by everybody, and you can get it free from health departments. But yeah, I agree with that. I mean, I always say Robert Kennedy must be rolling over in his grave if he saw what happened to his son. And, you know, the vehement anti-vaxxers with misinformation has damaged this so much. And so, yeah, I do think that would be a very small investment compared to so many ways we waste money.
I agree. Well, I'll pass that on to the few congresspeople that I know well. Okay, that's all of my questions. Dr. Farber, this has been fascinating, and it really helpful, because we are at a point where we've got more flu. I guess we didn't have much flu the last few years, maybe because of COVID. Now we've got flu. It's a serious flu. We've still got COVID. We've got RSV. So it's still, to your point, it's livable. We're living better than we did 2 years ago, but it's still out there. And your comments and your education to us today has been incredibly helpful. And I can't thank you enough on behalf of everyone at First Long Island and all of our clients and friends that are listening in. And I wish you a wonderful holiday season. And
you too, all of you. And Bob, I can't thank you enough for everything you've done for Northwell Health and for me. So thanks so much.
You know, and just one plug to Dr. Farber and Northwell Health. Northwell was the epicenter. North Shore LIJ or LIJ in Queens, we were the epicenter of COVID. And the effort and investment that was put in by the health system to help the community and to help the underserved communities that we have in our area of New York was just fantastic. And it's a privilege for me to be a trustee of Northwell and to have seen the incredible dedication of Dr. Farber and everyone else in the system to help the community through this horrific pandemic. So it's kudos to the system. And, you know, I just want everyone to realize that whereas the Nassau County Public Health Department isn't very much, and perhaps some of our government agencies didn't do as much as they could, I still wonder why things are under an emergency use authorization as opposed to finally being authorized. But I'll save that to another day. You know, Northwell really rose to the occasion on behalf of everyone that is in our catchment area. So I just wanted to make that pitch and that point to everybody. But Bruce, thank you so much.
All right. Talk to you soon, Bob.
Thank you. And thanks everybody for listening. Bye-bye.
Thank you. Have a wonderful day.
Stay healthy.